welcome everyone to our seminar today. The Centre for Maternal and Newborn Health, in association with the Birth Project here at Liverpool School of Tropical Medicine, are absolutely delighted to welcome Seth Cochran here to the seminar today. Seth is going to talk about obstetric fistula. He is the founder of the Fistula Foundation. He's a Cornell engineer and a graduate of Stanford Business School, and he's also an assistant professor at the BLH College of Medicine and a member of the Women's Global Health Clinical Study Group at the Royal College of Gynecologists and Obstetricians. And he's going to talk to us today about a unique opportunity to end the terrible injustice of obstetric fistula, which affects more than 1 million women globally, and how data visualization and predictive analysis can help to map gender inequality and end fistula for women everywhere. So you're more than welcome. We'll have a presentation for about 45 minutes. After that, we'll have time for interaction and some questions. People may come in and out during the seminar, so please bear with us. But Seth, over to you. You're so welcome.
Great, thank you so much. And thanks for everyone who's here and for coming. And I'd like to have a conversation, so I'm gonna show some slides, show some visualizations, and if you have any questions at any time, you're welcome to pop your hand up. But we'll try to have a lot of time for conversation, okay? So first, I think we are about 90% women in the room. So I figured I'd first address this question that is usually on people's mind, is like, what are you, a man, doing on this women's issue? So I'd tell you a little bit about my background. Who in here first has heard of obstetric fistula before? You can raise your hand. All right, we have a knowledgeable crowd. So my background's in engineering and operations research, applied probability, and I went to work in private equity right out of university and was like doing really well, making money. I'm from a working class background, so I thought that's what I wanted to do. And I quickly realized that it wasn't all it was cracked up to be, and I wanted to change my life. I was really inspired by the American Civil Rights Movement and people throwing their lives at gross injustices, specifically the people, and if anyone's familiar with this, people who marched in Selma, Alabama, who really their lives were at risk, but they were fighting for something that was just obvious and just a gross injustice. And I wanted to do that. I wanted to throw my life at something really unjust, but I'm straight, white, and male, and I don't really, there's not a lot of systematic injustices that affect me, so I had to find a way to find that injustice. And it's sort of a long story short, I tried a bunch of different things. And one of the things I did was raise money for cleft palate repair. So I really like surgery. It's very concrete, it's very tangible. And one of the donors from that project sent me an article about obstetric fistula. And I read this article, and I mean, it was a BBC article, nothing like dramatic, it was very factual. And I just knew as soon as I finished it that this was what I was gonna devote my life to. Like, this was my Selma, because for me, obstetric fistula is like the most concrete and addressable injustice that exists. It shouldn't happen, but it does. It's devastating, and we know how to fix it, but nobody gets fixed. Like, that's just, in every dimension, it's unjust. So when you see a man up here talking about fistula and about gender equality, these are because, for me, they're human issues. And I'm really happy to see everyone in the room, but I figured we'd start by just kind of giving some context. So you all know what obstetric fistula is, but do you know that it's as bad as losing both legs? So the Institute for Health Metrics and Evaluation, who knows about IHME? Anybody? They quantify disability. So how bad is it to have a different condition? And they do a really complex and sophisticated survey process to try to determine, just how burdensome a different health condition might be. And they do a lot of them now. But when I was first looking at this, like the disability rates for fistula, for rectovaginal fistula, so a connection between the rectum and the vagina, is about 0.498. Means that for every year you have a rectovaginal fistula, you lose half a year of healthy life, okay? Basically the equivalent disability is amputation of both legs with no treatment. So according to IHME, it's as bad having erectile vaginal fistula as it is, having your legs chopped off. So, so that's when we talk to people who are not familiar with the cause, like this is how we contextualize it for them. It's also a problem that has existed as long as people have existed. The picture on the slide is Queen Henhennet, an Egyptian princess from 2000 BC, and her mummified remains have an obstetric fistula, and that's the oldest recorded case that we have of fistula. So this has been happening forever, really, and it was an absolute scourge in the United States and Europe a couple hundred years ago, and the first fistula hospital that was built was in New York City, and this is a picture of it. It attracted people from all over the country. I mean, there's really compelling stories of women going miles and miles, planes, trains, automobiles, and on foot to get to this miracle solution. Sound very similar to if you interview women in rural Africa or South Asia now, they tell you the same stories. This hospital treated all the women who could afford that treatment, and in fact, they cleared the backlog. The referral systems were in place, so they actually tore this building down and they built something in its place. Does anybody have any idea what that was or what it is now? Waldorf Astoria in New York City. So, first fistula hospital, Waldorf Astoria. So, from our work, what we know is that surgery on average takes about 80 minutes, and women on average have lived with fistula for about 6 years. When they get that surgery, the effect on average is that they get about 10.6 years of healthy life back. So when we look at, is anyone familiar with the term of disability-adjusted life years? Okay, so this is, we can make really objective analysis of program impact if we look at a measurable that's comparable across conditions or efforts, and DALY is one of those metrics. So what we're able to do with the disability weights that we get from IHME and the information for each patient and her outcome of surgery, we can calculate how many years of healthy life we've been able to get back for her as a result of doing the surgery. And on average, we're getting 10.6 years of healthy life for each surgery that we do. So it's a really compelling, intervention. Despite its great impact and it's quite cheap too. We think it's anywhere between $200 and $500 to do a surgery. We have 1 million women on the planet who have fistula and are not being treated. We have about 50,000 cases every year, we think. We don't have good data for most, as you probably know, most issues concerning women. There's an absent data. There's a lot of people working on that, but what we know is that about 16,000 women are being treated every year, so we're not even cutting into the incidence, more or less attacking the prevalence. So there's really systematic issues. And what are those issues? What issues hold back our sector from addressing fistula in an effective way? The first is the organizations and governments that work on fistula, they don't really work well together. Like sometimes there's political fighting within the international NGOs. The stakes are really small. People are competing for a very small pie of funding. You'll see this in anything you do where there's a lot of competition. Some people call it collaboration, so we're working together, but not really well. We also know that the money that comes in doesn't always get to the people who can make the best use of it. There's a lot of people left out of the traditional funding models. And then finally, the global health sector thinks of fistula as a symptom, as something that is not in and of itself worthy of being addressed. I've heard it from a leading institution be referred to in a metaphor, why should we mop the floor when the water's still leaking, But we believe that fistula has a lot of potential to help address bigger systems issues, and that's what we're gonna really talk about. So I started Operation Fistula in 2008, really knowing nothing about health or Africa or women, and still don't know anything about women. My wife will tell you that. But I have learned a lot about health and about developing health systems. Because of my background, I've been invited to participate in a lot of strategic efforts of cutting across women's health, and so I've had a really good view of this. And what we're trying to do with Operation Fistula is we're trying to end this. You know, we believe that 1 million women is a small number relative to the 7 billion that we have on the planet. We think this is addressable, and it's important, neglected, and solvable. And so what we're trying to do, we have an organization that's created to try to engage different governments, multilaterals, international NGOs in an effort to find, treat, and reintegrate every single woman on the planet who has fistula. So we have a real end mentality in our organization. I'm here talking to you. I have the privilege to do that, but I am not representative of the organization. We are feminist, almost completely female organization. You can see our team is 80% women. Our board is 40% African, so we really believe that problems are solved by the people who are closest, that proximity has ultimate power. So we try to engage people to lead us to the strategies that we want to implement. I think it's important to note that, like, I have the opportunity to be here and talk, but the organization looks a lot different. We also have incredible funders. We're funded primarily by high net worth individuals and their family foundations, but also some corporate foundations, namely Tableau and Cartier. Google supported us, and White and Case as well. We've also been funded by the UNFPA Population Fund, but these partners have really in the last, I'd say 2 years, helped us build an organization. Maybe 3 years ago, it was kind of me, and now we built this into a proper organization. We're based in London, near Clapham Junction. So what do we do? So coming back to the problems that we framed that exist in our sector, we have 3 different programs. Okay, so first we call Go Far Together, and I'm going to talk a little bit more about each of these. So Go Far stands for the Global Obstetric Fistula Automated Registry. Okay, so GOFAR. And this is where we're using technology to try to drive inter-organizational collaboration. So we're going to show how we're doing that. We also have a program that we call Fund Patient Care, and this is where we use a unique funding model to put cash directly to the point of care that's driven by data. And these, when you have a strong data structure using technology and a funding mechanism that is driven by data, you start to collect a lot of data, okay? And we actually believe that data can help us map system vulnerabilities. So that's our 3rd program area. And we're going to talk a little bit about each of these, and I'm going to bounce in between PowerPoint and between Tableau, which is our data visualization software, to show you some examples of how we do the work. So you've probably heard of this. If you want to go fast, go alone, and if you want to go far, go together. So this is kind of the branding that we've put together. So the idea is go far together, right? We work together. We go farther if we work together. So who's ever collected data in a developing sort of world? Yeah, it's hard, right? It's hard, especially because you have to come up with the right questions. You have to get the papers printed. They get distributed. They have to be filled out, checked, collected, entered, analyzed. It's a big lift. We're in an academic institution, a leading academic institution, so the people who are here really understand how that works. But there are a lot of people who are not academics who have a lot to offer, and they don't have any voice, right? And if we do include their voices, we can make programs that are more appropriate and effective. So what we say is we turn, this is a relatively well-designed records room in a hospital, and all that data lives in Excel, and people have huge Excel files that they don't really do anything with. So what we say is we turn this into this, right? An interactive, beautiful visualization that tells a story, and we're going to walk through some of these a little bit later. This might not be relevant, but I like to talk about it because the technology that we use is nothing that's specific to us. Everything is available to anyone here. You could get any part of this stack. So I always want to show what we use. So for data collection, we use ComCare, which is a development sector standard. We also use Airtable. If you've never tried Airtable, on a personal level, it will be valuable to you. It's like Excel in the cloud. So it's a relational database that's really easy to use. We've started to test Dharma, which is another data collection tool that works offline. All these tools have to work offline in low resource environments. That data then goes into the cloud, and we manage it with Exasol. Exasol is an in-memory, enterprise-grade database management system. So most of the tools we use are designed for business, by business. So there's a commercial motive for these companies to make amazing products, and they will continue to invest. And the level of investment that companies make in their technology is like multitudes higher than what we as a sector can invest. Just to give you an example, Salesforce.com invests $1 billion in R&D every year, right? So Tableau invests a couple $100 million. We as a sector probably spend 50. It's best guess, we don't even know. But Exasol is our database management system. We then do data cleansing and pivoting with Alteryx, and we visualize it with Tableau. Tableau Foundation provides software and training to nonprofits and even small. We have a large grant with them, but even smaller charitable efforts will be eligible. And if in your work you ever want to use these tools, email me or our team, and we'll help put you in touch with anybody who can get you access to some of these things. For Go Far Together, we had a 5-country pilot last year with the UNFPA Innovation Fund. And we worked in Nepal, Malawi, Madagascar, Cameroon, and Bangladesh. Just a quick visualization of the sites that we installed our technology. In the next section, we talk about how we fund work. I'm going to show you some examples of how we use that. Actually, I'm going to show you now. So bear with me one second. Okay, so you see this okay? Okay, so basically, imagine like someone in a hospital using a tablet. Like they're instead of writing things on a piece of paper, they're answering questions on a tablet. Now that electronic interface allows you to do things that you can't really do with paper. Like you've seen things on a form that say, if you answer yes to this question, go to page 7 and answer these other things. Well, a digital interface allows you to make those conditional things happen immediately, and so you can go down different paths of inquiry in an automated fashion. So as that stuff goes into the cloud, our tools kind of pivot the data and set it up to go into these automated visualizations, and this is an example of what we use in our program in Madagascar. And so you'll see the surgeon will be able to look. These are the different districts in this region of Sava, okay? So we believe that where women have lived longer with a fistula, it's likely that there's more fistula, there's a higher unmet need. So in this case, you can't see the letters or the numbers. So in Ndapa, the average years of leaking are 11.4 years, right? Whereas in Sambava, it's 7 years. And that kind of makes sense. Our major treatment center is in Sambava, and so they're kind of catching more of the patients. The people who are coming are not having to wait a long time for it, whereas people from Ndapa, they're waiting a long time before they can get to treatment. So this could help drive programming to like push more mobilization capacity to that district. Okay. Also, each of these dots represents a place. A place being a Fokatani. Now, a Fokatani is a collection of villages. Those roll up into communes. Communes roll up into districts, and districts roll up into regions. So we really believe geography can lead to a lot of programmatic planning and learning. And here you can click on any one of these dots, and it'll list the patients who are attached with that. And we've anonymized this in a demo just to give you an example of what this partner uses. He likes to have really visual cues about all these different factors. So this woman had very little education. She had one child, and it was stillborn. Her reproductive timeline, she had a late start to her menstruation, and her first pregnancy, she got a fistula, and she's had to wait 22 years to get treated, okay? So you start to, if you just start to look through this, he managed, yeah, go ahead.
Sorry, can fistulas be repaired long after like a birth injury?
They can, yeah.
Like reversed?
They can. The best time to, depending on the nature of the fistula, like some are really small, and if they're really small and it's immediate after birth, you don't even need to do surgery. You can catheterize, clean the wound, give her antibiotics, and they'll heal. We as a sector believe that approximately 20% of patients fit this. We call it conservative management of care. Other women who have had it for decades, what happens is the fistula creates, when you have that whole, fistula means an unnatural connection, okay? So that unnatural connection essentially scars, and the scarring is what maintains that fistula. So when they do a surgery, what they do is think of the bladder, the vagina, and the rectum as three distinct, systems. And what they do is they excise around the scarred tissue, and then they mobilize fresh tissue, and then that's how they close it. They essentially, so if a woman's had it for a really long time, she can still get treated. With older patients who are postmenopausal, it becomes more challenging because as I understand it, the flexibility of their vaginal tissue is changed, and we've seen some very old patients who have a really hard time. It's even hard to examine those patients because of that. Thanks for your question. This surgeon also really he likes to look at what he thought was going to happen versus what did. So here you can see he has at his surgery what he predicted was going to happen, like he thought she was going to be continent, and then what actually happened. And here he's got a pretty reasonable size of missing information, so we would help him eliminate that, right, so that we can have a better view. You can also see the complexity of fistula that he treats. He's conservative, so he'll stick to the simpler cases, even though he's one of the best surgeons in Madagascar, because a woman's best chance at recovery is her first surgery. So you really want to make sure the right person does the first surgery, and this is one of our best partners in our project lead in Madagascar. He's very conservative. And then of course you can see all of his patients. Now, as we start to get this data from different fistula surgeries, we believe can help us identify points of inequity and inequality. And I'll show you an example from Malawi. And what we've done is we have one of our partners has given us 1,800 records of fistula patients. And this visualization is looking at the fistula patients and their tribal affiliation relative to the population and the population's tribal affiliation. So you can see the different tribes in Malawi are here. And if you look at this slide first, because this is the population, we have 27,000 records. This is from UNICEF mixed data. This is open data that you can request. And so if we look at, for example, the Yao tribe, you can see here that 23% of the Yao population of Malawi live in Mangochi district, and 19% live in Machinga. But with the fistula patients that this partner's treated, 45% live in Machinga. That's a pretty interesting disparity. Why is that? Is it because that, maybe in the Yao culture, relatively speaking, that in Machinga they're lower on the, or they face greater inequities? Or is it because this partner has a patient mobilization scheme where they've seen patients come from Machinga and then go back and get more patients? We don't know, but the visualization, it provokes questions, it provokes conversation, provokes a better conversation. And when we talk and we think, we figure out how to do things better, how to identify where there might be other opportunities to do our work better. So, and of course this works with every other tribe. I mean, there's probably other things here, you can see this, there's differences in population. And that anytime there's variation or differences, this should make you investigate why, okay? So going back to, let me just close these. My computer will totally crash. Okay, so, there we go. See, I shouldn't have said it. Oh, here we go. Oh, it still works. Okay, good. Okay, so I'm going to talk a little bit about the next program, our second program, Fund Patient Care. I'm going to tell you first about the pilot we did, and then how our funding work has split into two kind of segmented projects. So in 2012, this map came out, and this is not done with Tableau, but it was the first time we'd ever seen data visualized, and it was amazing because it allowed us to look at all these different dots on the map and compare it to where all the funders reported treating or funding treatment. And we realized that like 80% of the people who were doing work were not getting funded from traditional funders. So, so what we did is we talked to a lot of these African surgeons and asked them, like, you know, why? What's wrong? And what we discovered is that a lot of them, in order to receive international funding, they needed to have like a team of accountants to do this governance sort of reporting. And a lot of the governance reporting that's from our, you know, from the way we think about things is based on a lack of trust, right? We want to know exactly what you're going to spend your money on and make sure that you're not stealing it. You know, there's like a really bad structure, right? We're missing kind of the picture that a lot of the people who are doing this work are very worthy of funding and are very leveraged, very resourceful. They can really make that funding do amazing things if you just trust them to do it. So what we wanted to do was create a system that did trust people, but verified the quality of their function with data. So we made this pilot program where we essentially focused on finding great surgeons, screening that they were capable to do the surgeries, and then paying them unrestricted funding to perform those surgeries. So what we did is we essentially, instead of giving them a grant and then all that money up front and then asking for them to do reports, we gave them a contract where we said, hey, you can do 50 surgeries and we're going to pay you like $200 a piece, and you're only going to get the money when you report what you've done, right? And so as we get those reports, we can confirm that quality's been done. We issue the money, it's unrestricted. You can spend it any way you want as long as it's not terrorism, politics, or religion, which is US federal tax law. Of course, also good ethics. People were kind of blown away by this, right? Like, what, I'm gonna get this money? And all we required them to do was fill out this paper form, right? Where they had to answer some questions. It was a 1-page, front and back. Back then, we gave them little cameras, right? This was 2012. In the course of this pilot, of course, smartphones came, and they all got really sophisticated with scanning of the paper with their phones. And then we brought these things in, and we typed it into Excel. And a lot of this effort informed the GoFar work because, you know, you make errors when you type things in from Excel. It's really time-consuming, and you know, you can get efficiencies. You can treat more women instead of paying people to type stuff into Excel. But what we really saw was the impact on the providers of care. So this is Dr. Fidel Rokoto Ari Vololonana. There's always a second syllable there I missed, but he's our lead surgeon in Madagascar. And when we met him in 2013, he had, in his 30 years of care in Sava, he had treated 63 cases. And his success levels were like mid-60s because he had no training, he had no understanding of how to do that. But he was dedicated, meticulous, like really, he was on mission. And what we thought is, like, if we get this guy some support, you know, he can be who he is, right? And like, one of the things that I really believe is that human capability is equally distributed. You know, there's amazing people in these very poor situations, and we don't need to go out and empower them. We need to get barriers out of their way, because they're already empowered. You know, we have to remove things or put them in a place where they can be who they are. And Fidel was one of those people. So we started to give him performance-based funding, and in the first year, he treated 75 cases, and he had like north of 90% success rates because we helped him figure out how to pick the right cases. He had some training. He knew how to treat them. He's gone on to become a FIGO fellow. So FIGO has a fellowship training fistula surgeons. And he's probably the best surgeon in Madagascar. He's done hundreds of cases. If not, he's probably crested 1,000 now. And he's really a leader in the country, you know, and he's really blossomed, and he continues to, you know, strength after strength blossom. So it's not just this one example of Fidel. When you distribute funds to people who do work, and you let them have the flexibility to use it however they want, including keeping it, paying their kids' school fees, buying land, whatever they want to do, magical things happen. In Madagascar, when we started working there had only been 58 patients treated in 2012. We went in to work with UNFPA. We did 2 years of work. In the first year, together, we saw 245 cases treated. Okay, that's a pretty crazy growth rate. But the second year, We doubled it again, right? At this point, Operation Fistula said, well, we can't put any more performance-based funding, and we need to figure out what we're going to do next. We're not going to fund anymore. So Operation Fistula funding goes away. What happens? Does the project collapse? No, it doesn't. What happens is they continue to grow because these people are motivated. They're fired up. Like African people, surgeons, most of my experience, are extremely resourceful. And they once they get motivated to an issue, they start making things happen. So our funding kind of catalyzed their interest in this. Treating these women is probably one of the most compelling things that you'll experience. If you, in your work in the field, you'll see fistula patients, it'll break your heart. You'll see them treated, it'll inspire you to devote your energies to helping do that more. And that's what these surgeons, I think, see. It continued to grow over the next 2 years. I don't have the data from 2018, so I'm not sure where it is now, but it's, the effect has been really strong. We've seen similar, not quite as aggressive growth in other countries. So what we did, the response that we had, we've got 2 different programs. The first we call Project Free. And based on the work that we did, the government of Madagascar said, well, this would work if we scaled it. You know, we might be able to end fistula in these 2 regions. So this is what the Project Free is, an effort to treat every single patient in a given place. And these are the 2 regions we're working, Sava and Batovavi Fitfanan. There are 10 districts in these 2 regions and 218 communes. We're now making a plan. We started this last year. We believed that to end fistula, it was a linear process. You know, you had to find them, you had to treat them, you had to take care of them after they were operated, post-operatively, then you had to reintegrate them, just step by step by step. What we learned is that the community function and the clinical function are not distinct. They are very much interrelated. And we have since kind of developed this idea that it's a working concept for us right now, but we're calling it the heal wheel. And it happens that people don't always follow a linear path. You know, you might have somebody who's been informed that fistula surgery could be available, and they immediately mobilize themselves. They don't need any help. You know, some women are either not willing or not able, and they have to be supported in their mobilization to the facility. With treatment, there's a whole process around diagnostics and determining where a patient should be. You know, what level of severity is her injury? And then, of course, the rebuilding of a woman's life is a very complex issue. And some of it is very much informed by trauma. Some of them have experienced incredible trauma. So counseling is essential, and psychological support, social support within their communities. I don't want to spend too much time on this. I would spend the whole talk on this, but if anyone wants to talk more about this, we can talk after. We've got interest from the government of Canada through Grand Challenges Canada to fund a scale-up of our projects in these 2 regions, where we are looking at the orange areas is where we would eradicate fistula in those communes. So there are 50 communes of the 218, and that would be our first step. And so we're in the heat of this right now. In fact, we were just submitting paperwork yesterday, and so wish us luck. The second project we have under our Fund Patient Care program is what we call Kickstart. So it's essentially what we did in the pilot, but now issued to people who are using GoFar. Okay, so if we have users of GoFar, they're eligible for Kickstart funding. And the way that works is they would put the information into GoFar. That would then be put into the cloud, and we would analyze that, or they would have reports, dashboards, and then they would get money for that. And so we're just starting to launch that now. And I think we have 15 countries who are in the queue for this. So it's really a function of money. I mean, and that money will go right through to the people in need. So if anybody knows any philanthropists, you can come and talk to me. Okay, so the final program that we have is MAP vulnerabilities. And we believe, I mean, fistula only happens where systems fail women and girls, okay? So the existence of fistula is in and of itself evidence of systematic failure affecting women and girls. So we have all this data. You know, when there's a maternal mortality, you can do audits and talk to people about why, but But you can't, wouldn't it be amazing if you could talk to the woman and say, what happened? Like, how did you die? Well, with fistula, like, we can, because a woman with fistula is like a maternal mortality that you can interview. And when you take that information that this woman can give you and you couple it with geographic specific data, it opens up this huge treasure trove of really informative data. Not just to understand where there's problems, but to also understand how you're resolving those problems. So I'm going to show you, before I jump into the next part of this, a couple of visualizations that give you an example of how this could work, okay? And this is a really early thing for us. Like we're working on exactly how this works. Okay, so this is from a partner in Bangladesh. And this was where we didn't ask our questions. They have their own questions, and we built an app that was matched exactly with their paper records. And then someone went in and like took the paper and typed it in the app, and then we had a digital version of their data, and we built this and a couple other things for them. But what I think is interesting to show you is just kind of how this works, right? So this is how long women have been leaking. This facility, almost half of the patients they treated are within a year. So they're having like a really strong, engagement with community to get these patients to come in. But almost 1 in 5 has waited 20 years. So there's still clearly unmet need in their catchment area. There is some seasonality, which makes sense. We see that there are highs in March and November, which track to the rainy seasons. Or these would be the dry seasons, obviously. But this is the chart that really kind of blows our minds, okay? So this is the first pregnancy age on this axis combined with the wedding age. And so these would be girls who were married at 15 and pregnant at 15, right? So this population here, these are women who've experienced extreme gender-based violence, okay? These are children, okay? And if you even go a little further, like really 80% of the data set, these are women who are married as teens and had babies as teens. So you have like a real hot spot of child marriage, right? So in treating or doing our work with fistula, we can then understand where there's a hot spot of child marriage, and that data can be passed to organizations and governments who are focused on that. Like Girls Not Brides, for example, could facilitate an effort on this. Another example that I wanted to show you is around Bangladesh. We did something similar. This was part of our UNFPA program where we had 3 different facilities do the same thing where we digitized their paper records. We adjusted ComCare to be exactly congruent with their forms, and then people entered it in, and we had all this data. So we had, from 3 facilities, one we had 2 years, another 18 months, and another a year. Now in Bangladesh, we always try to work with government, okay, because government is really the path to scale, and if you're not working with government, it's just a pilot, right? And if you can't replicate at that scale, then your impacts will always be constrained. So the government of Bangladesh, when we met with them and UNFPA, highlighted that they're having increased rates of assisted delivery, like more women are coming to the facilities to give birth. So you see higher rates of iatrogenic fistula because the quality level of care, it takes time to develop. It doesn't always, you don't just have people show up and all of a sudden quality's there. Experience builds better quality. So we know in Bangladesh, and the thing to look at here is, these are the causes of fistula. So the dark orange is iatrogenic, okay? The orange is obstetric, meaning caused from prolonged obstructed labor. The other ones are other, essentially. So if we know, where iatrogenic fistula is happening, well, that could lead the government to focus on specific areas to do capacity improvement. Rather than saying, we're going to do everything at a national level, they can do precision public health and focus on exactly where that issue might be. So in our questionnaires, we ask for the actual facility where the iatrogenic event happened, so we'll be able to map a specific facility. In this case, they just ask for the type of fistula. So if we look at each of these different subnational areas, and in Bangladesh there are divisions, that's their sort of regional model. if you click here, you can see that in Khulna district or division, it's 35%. Okay, so that's pretty much in line with the national level, which was, I think, 34, right? So 34%. In this division, let's see which is, I don't know the name of it. Anybody know the name of this division? Bangladesh? Pop question, pop quiz. It's 22%. Okay, so it's a little bit better than the national average. But in this division, it's 2 out of 3 of the patients that were treated were got their fistulas from iatrogenic reasons. So we know in this division there could be, we can't say with certainty, this is not research paper level evidence, but it does generate a conversation, right? So there might be ways that we could get more information, which facilities do these women come from. The idea is having these pictures, right? These charts that you can play with, that you can talk with. Everybody can understand, you know, like you don't have to be a statistician and know p-values and work out like what the level of impact is. You can see things and that drives you to ask better questions. It also gives people who are not trained as researchers to have a voice. And so we think there's a really unique opportunity now to leverage the technologies and the people who know how to use them. So just to talk for a second about what these technologies are, okay? When we started to think about how we wanted to use technology in our fistula work, like most charities, we said, oh, we're gonna build an app, okay? But you know, like we're not in the app building business, right? There are companies that spend millions of dollars and they don't do apps very well, right? So what we wanted to do is find private sector tools. And I'm from the private sector. Before I started Operation Fistula, I was working in private equity. And so I wanted to go back and use some of the tools that I knew. But I discovered that there's been this huge revolution in technology. And everybody's heard of big data, right? This big data, like kind of a nebulous term. Nobody really knows what it means. But a lot of it is about taking your data, you know, and like from your phone and your location and all this. There's a lot of data collection. But there's another section of the big data sphere that's called business intelligence, okay? And what that is data scientists working in companies, banks, insurance companies, studying all the data that they have to figure out how they can make more money out of us. And it works, right? What would have happened in the past is the marketing department would have an idea. They would call the business intelligence division, who would do an analysis, give it back to the marketing department. Marketing department would change their program, make more money for the company. Well, people realized that chain was a little bit too long and it was too heavy on experts. Data scientists are in short supply, they're very expensive. So they started to develop new technology tools called self-service analytics. So you can do your own analysis yourself. And so Tableau is self-service analytics. Ultrex is self-service analytics. So we believe that these self-service analytics tools are really powerful. We believe that because they've completely revolutionized the private sector. Every single industry and every single function has been completely transformed in the last decade by these tools. But our sector hasn't touched them. So we believe that it's imminent and that we want to use these tools for social good. And a lot of the people who work in these companies want to do it too. So there is a program called Makeover Monday where people who want to learn how to use Tableau practice on different data sets to build visualizations. And for International Women's Day, we partnered with the people who do Makeover Monday, and we gave a data set around gender. And we had 83 visualizations produced in a week by the community of professionals who use these tools. These visualizations gave really interesting perspectives on the dimensionality of the data. We gave a particularly broad set of data. But there are so many people who want to contribute their skills with the data that we have to try to help us understand where gender inequality is most pronounced. So the first project that we have under our MAP Vulnerabilities program, we're calling it Visualize Gender Equality, and we're doing it in partnership with the Tableau Foundation, and with, nothing is yet confirmed, but with several other organizations that do gender data. So you have the data people who really understand the data and technology. You have the gender people who really understand the dimensionality of gender and all the work that is done. And you have the data gender people. There's a small group of people who are data oriented but also have that gender dimension. So we're trying to corral all those people together and do a project where we leverage the public data that exists along with some proprietary data to better map where gender inequality is most pronounced, which would then, of course, allow the people who address the certain aspects of that to address it more effectively and precisely. So that's how we are trying to end fistula for every woman everywhere. And how am I doing on time? Oh, I'm a little bit late, but I'm sorry to go on a little bit, but I'd love to take any questions or hear any comments. And thank you all for coming too, by the way. I really appreciate your time.
Thanks so much, Seth. So we have got about 10 minutes for questions. I think as a midwife, I'm really passionate about this as well, and I think what Seth and his team are doing is inspirational and it's fantastic. And you spoke about collaboration, and I think that that's essential because I'm a clinician, but you talked a lot about data, and I'm glad that our head of M&E is here because you need clinicians and people who work with data, and you also need funders. So it is a collaborative effort if we are actually going to tackle some of these inequalities in maternal health across the globe. And of the 76 countdown countries, which is the countries that are trying to attain the Sustainable Development Goals, only 72 of those countries have actually got the workforce that they need in maternal and newborn health to actually tackle obstetric fistula, which happens because of obstructed labour. So maybe the midwife or the healthcare professional is not able to get the woman to the proper care that she needs. So Seth is talking about what to do once it occurs, but it's also preventable, which is what we want. So it's great to have you here, and we really thank you for coming. And just before we move to the questions, in front of you, you will see a postcard, and that's about the Birth Project. So CMNH were the scientific advisors for the Birth Project, which is a collaboration between the sciences and also the arts, which produced a series of plays around inequalities in maternal health. So do have a look at the website, and Laura's here as well if you want to talk to her afterwards. And it's another way to actually show about maternal health and how we can actually improve it. And really, once we get that message across, that's when we're going to actually see a change. So thank you so much for coming, Seth. And please, questions. We've got about 10 minutes.
I saw you first, sorry.
Hey, my name is Mary. I just had a question about the reincidence rates. Do you guys have any data regarding that of the women or any follow-up with them?
It's really funny that you asked that because I just was asked that last night by the Canada team. We don't know. Partly because there's not any really good outcome data post-discharge. And the reason that isn't happening is because there's not an integration on the community side of things. The clinical, once they discharge that patient, like the general thinking, which is totally wrong, is if she doesn't come back, everything's good, right? What we know is that these women are really marginalized, and a lot of them haven't been able to have sex. When they get their fistula repaired, they can then, and they're a lot of times they're so traumatized that they're not able to withstand. Like I think they're advised 6 months that they shouldn't do that, and that'll be a contributor to recurrence. Another is if they get pregnant again, they have to have a C-section, to prevent obstructed labor. We don't have the data. We don't know yet. We will. We have to, right? But thanks. That's a great question. Sorry.
I think your backstory and your transition, like from whatever exactly it was that you were doing beforehand into starting this foundation, is really relatable and inspirational to probably a lot of people here. But how did you bridge that gap from your previous work life to I'm going to take on this new thing that I don't necessarily have a lot of experience with?
Yeah, it's also a really good question, and I do talk to people a lot about mentor entrepreneurs and people who are doing career transitions as personal, and really the core ingredient is perseverance and just not stopping because, and that's why you really need to be deeply motivated, like deeply, not topically, but in your heart. And I went through a process to figure that out for me, and that's why this thing came about. And I didn't even think about the fact that it would broadly be considered a woman's issue. I was just like, this is a person suffering, right? And I was so committed to this. And you know, you get lucky. Basically, the reason I would say this is perseverance gives you the time to get lucky, right? You just have to keep motoring on, and you'll make mistakes, and you just have to keep trying. For me, I was fortunate because my education and my experience is very relatable. It's around operations, making enterprises work more effectively, using data. I studied operations research, so it's like really, it fit with a lot of other programming. So as I was on this journey, I was hired I started a Club Foot charity for some philanthropists, and I did a turnaround thing with Concern around maternal health, and then I did a fellowship with Ashoka for maternal. I kept getting into all these I worked for the University of North Carolina on PMT, CT stuff in Zambia. So I was like keeping myself going by doing these little consulting projects that were all highly relevant to the mission, right? So I was like picking up relevant skills while I was doing stuff for other people, while I was continuing to try to keep Operation Fistula, keep the dream alive. And then, you know, I met Nick Jenkins, who was our first major donor from the Dragon's Den. You might know Nick Jenkins. He met me in 2015, and he's like a great mentor, and not just giving money, but giving a lot of advice and turning, you know, this fistula dream into a functioning organization. So, sorry, a little bit of a meandering answer, but I think that's kind of the path, right? You just kind of, you have to go for it and keep going for it. I usually put up a slide at the end, which is a man falling off a horse, a samurai. Because in Japan, there's a saying that success is falling down 7 times and getting up 8. And that's what I believe, you know, is just keep going.
Yeah, I'm also a midwife, so I'm interested in, I know that you were talking about the data and you've given it to other organisations to do with child marriage. Do you also use that data where obviously there's like pockets of where it's really prevalent? Are you using that to give it to other, or are you, your organisation helping with the prevention of it at all? I'm just wondering.
Yeah, great question. I mean, I had a lot of struggle. Because really, I want to focus on treating the backlog of cases, like the 1 million women that have fistula, and setting up referral systems so that when new women get fistula, they can get treated. But fistula has such a broad set of contributing factors that cause it that how do you prevent it, like, and without losing your focus, right? And it's the data that has been, for me, the answer that makes me really comfortable, that in doing our treatment of the backlog, if we can produce meaningful data that can help inform other organizations who are focused on those higher stream activities, to me, that at this point, that's where we are. We have started to say, how do we know that there is follow-up that happens? Like, how do we learn of that? And then, of course, you know, there's so many tangential causes, like with midwifery, for example. You know, broad-based, accessible, quality midwifery could prevent not just fistula, but a lot of other morbidities, a lot of child mortality, a lot of probably almost all maternal mortality, because most maternal mortalities are caused by very addressable and cost-effectively addressable issues. So it's a distribution question, and midwifery would be the best point of that distribution. So we work with UNFPA, whose mandate is 0 maternal mortality, 0 gender-based violence, and access to family planning. And in our work, we can really support that mission. And where the fistula work lives is within the midwifery function. So we were talking with them about, I was just speaking earlier about, you know, a plan to get 1 million midwives. There's I think 500,000 now. There should be probably more than 1.5 million, you know, to effectively do this. So we are too small and too focused to do a lot of this stuff, but what we can do is provide a map, you know, for people to execute it and facilitate those partnerships. Yeah.
Are all of your projects faced with the people who are already in country, so surgeons who are already in country? I know you told us the story about the gentleman that had increased
Fidel,
his,
yeah.
or do you have other people coming in and training surgeons in the country, or?
We haven't, okay, so a lot of that work that I did with cleft palate, there were people who were coming in and doing these surgeries and then leaving, and that's not, like, we don't really think that's the best long-term strategy for sustainable capacity. So we fund African and South Asian surgeons who are there. That's the funding that we would do. However, there are international surgeons who are trainers. We don't have a training function, but we are in discussions with FIGO to assist, like, with all of our data, and we've gotten pretty good at raising funds from corporate and high net worth, and so we can help facilitate the growth of their program. They have a training program that's mentor-led and capacity or competency-based. So, what we would do is focus on our core strength and then make partnerships with others, organizations who have different strengths. But yeah, you have to build, the capacity has to stay there, you know? It has to stay there for it to deliver long-term value.
I think we may have time for one more question, and then we'll need to wrap it up. Any other questions? If not, then we just want to thank you again, Seth. That was a wonderful presentation, and Seth will be around outside if anybody wants to get chatting to him again. So thank you so much.